All right, well, it's 12 o'clock and we have a full show for you today. I want to thank you for joining us. My name is Natalie Schaefer. I am the Executive Director for the North Lincoln Hospital Foundation. And for those of you I haven't met, that wouldn't be too much of a surprise because I just started June 1 of this year. I'm very pleased to welcome you to Hospice 101. Hospice can enhance the quality of life at the end of life through compassionate, holistic care. During this MedTalk, Karen and Teresa will explain the basics of hospice care, what it is, how it works, and the services offered throughout Linn, Benton, and Lincoln counties. Questions are encouraged through the chat function on your screen. So the chat is the little circle with the 2 lines in it, and that's how we're going to take your questions. I will be monitoring the chat throughout the entire presentation, and we will actually stop Karen and Teresa now and then to ask some questions. So that will be the way to submit your questions, please, through the chat function. We want to also thank the Oregon Coast Bank for sponsoring this session. So let me introduce our presenters. First, I'll introduce Karen Daly. She's an RN and a CHM with Samaritan Evergreen Hospice. She's the director. Karen has been a hospice nurse for 16 years and has spent the last 6 years in hospice leadership. She loves the team camaraderie, supporting staff in doing such good work and contributing to patients' comfort and dignity at such an important transition time. Working as a director during the pandemic has given her great appreciation for staff resiliency and flexibility, which in turn translate to great patient care by the team. In her downtime, she enjoys backpacking, knitting, gardening, and anything else that can get her outside. I'd also like to introduce Teresa Karlik, an RN with the Samaritan Evergreen Hospice. She's a manager on the coast. Teresa has been serving hospice patients and their loved ones at Samaritan Health Services for 15 years. She graduated from Linfield College in 1998 and has been a hospice nurse her whole career. Teresa moved to Newport 15 years ago and started working for Samaritan Home Health and Hospice as a case manager. She has been the manager of Samaritan Evergreen Hospice at the coast for the last 3 years, and in 2019, she was elected to the Oregon Hospice and Palliative Care Board, where she now serves as secretary. So Karen and Teresa, let me turn it over to you.
Thank you so much, Natalie. We are so happy to be here and happy to have you guys join us today. Like Natalie said, my name is Teresa Karlik, and what brought me to hospice, I always knew I wanted to be a nurse and have enjoyed that role as a nurse, and teaching about hospice and end-of-life care is my passion. So excited to have you here today. Knew during nursing school, when everybody else was afraid to take care of those dying patients, that's where I wanted to be. So that's how I've got here today. Thank you.
Thanks so much for the warm welcome, Natalie. My name's Karen Daly. I'm the director of Samaritan Evergreen Hospice. Similarly to Teresa, my path has really kind of led me to this specialty. I did some time in mental health nursing and then critical care, and this is a perfect melding of those practices. Contrary to what folks might think, hospice, it's a very joyous field. There's lots of opportunity for laughter, connection, intimacy. So it's my happy place. I'm so glad to be here and share a little glimpse of that with you. So some of the goals we'll touch on today, we want to go ahead and introduce you to hospice as a team, give you a little background about that, let you know which patients qualify, who pays for hospice, what are the benefit periods, how to refer to hospice, and when to come on service. When is it appropriate to start reaching out and thinking about hospice care? We'll give an overview of our service area, and then we'll highlight our hospice house in Albany, which is one of 3 hospice houses in the state. And we'll tell you a little bit more about that as we go.
So anytime I'm ready to introduce hospice to a new group of people, to families that I've just met, there's always a lot of questions. And I always want to start that we are happy. I love presenting. I love having feedback and questions during this, a little different now that we're doing virtual. So I want to open it up to just a quick, does anybody have a burning question, worry that they would like to ask us before we get started? Okay. Please feel free to ask us as we go along, because we are excited to answer any questions you may have.
And
So-
remember that you can put your question in the chat, and I'll be happy to ask those questions as we go along.
So a brief introduction of who we are. We are part of Samaritan Health Services, with the hospitals serving our communities in Corvallis, Albany, Lebanon, Newport, and Lincoln City. 55 clinics spread throughout 6 counties. Any of those can be referred to Evergreen Hospice. And we are a not-for-profit hospice that has been serving our communities for over 30 years. So those counties that we serve are Benton, Lincoln, Linn, Marion, Polk, and Tillamook counties. And hospice is for anybody wherever they call home. So we go into private homes, foster homes, nursing homes, assisted living, anywhere that the patient or family can use our support. So Samaritan Evergreen Hospice started back in the 80s. We became Medicare and Medicaid certified, so following all the rules and regulations of Medicare. And we joined Samaritan Albany General Hospital in the mid-80s. In August of 2012 is when Samaritan Evergreen Hospice House was built, funded by the foundation through Albany General Hospital and community donations. And then in 2019, our programs on the coast, Pacific Communities Hospital and North Lincoln Hospital in Lincoln City, joined under Samaritan Evergreen Hospice to expand the service area. This year, in March of 2020, actually, the pandemic changed a little bit of how we had to take care of our patients, and lots of changes. We were able to start doing some telemedicine for those who were worried about people coming in and out of their houses. And also, we continued to make our normal home visits. We were concerned that we'd have a decline in census as the pandemic started, but we were honored to serve in 2020 1,515 patients throughout our service area. And this is a map of who we are. I'll turn it over to Karen.
Thank you. So wanted to talk a little bit about the hospice team, and sort of in the background, we have our medical director, Dr. Looney, who's responsible for oversight for the whole program, Coast and Valley. We have nurse practitioners, Katrina Hoffman, Alyssa Caminata, and Coast physicians, Alexa LaFonce and Jerry Robbins. We have on the hospice team, every patient and family will have assigned to them an RN case manager. And this is a nurse that really works intimately with your family, develops that patient plan of care, and makes sure you're prepared for what might be coming. And we also have pharmacists available for consults. We have certified nursing assistants who provide bathing, showering, nail care, hair washing, changing linen. They can also do light housekeeping. We have social workers available for support and resource management. We have chaplains that serve our patient really in whatever capacity they is a best fit for them. So our chaplains are available for non-denominational spiritual support as well as specific denomination support. We have bereavement counselors that are available for counseling throughout the hospice process, and then available for 13 months after a patient dies to support the family and friends, care workers. We have music and massage therapy that come out to patients' homes to provide some relaxation. And we contract with occupational, physical, and speech therapists in order to meet their patients' needs for comfort. We also have volunteers that are an amazing part of our program, and they can do anything from companionship to errands, yard work, music. They're really a skilled, valuable set of our team. And then we have pet therapy too. And we have, the next slide is our hospice house cat, Cupcake. She adopted us probably 2 years ago, and we joke that she's kind of our informal leader. We do what she says.
Yeah, we absolutely love Cupcake. So I wanted to start out with hospice myths that you may hear a lot of, and I talk a little bit through those. It's always interesting to me what I hear out in the community about what people believe on hospice. So hospice makes you stop eating. And this is something that we hear a lot of the time, and this is so not true. What happens is the body starts to shut down and is close to the end of life. The ability to process food and fluids just slows down, and patients can't eat or drink very well. And it can cause more problems if we force eating or drinking. And so we say we want our patients to eat what sounds good, when it sounds good, whenever they can, which may be a couple bites in the morning, a couple bites in the afternoon. It may be that they're having a great day and they want to eat. And so we say what sounds good, when it sounds good, but just not to force. And a lot of times I hear patients say to me, my family really wants me to eat and I just can't, but I don't know how to tell them that I can't eat. And then the family comes to me and says they won't eat, and if they don't eat, they're just going to continue to get worse. So we, through our team management, bring everybody together to talk about what it looks like at the end of life. Why is it that somebody doesn't want to eat or drink? Why is it that we don't want to offer artificial food and fluids? It hurts the body more than it helps. And that same line, hospice makes you stop taking your pills. No, we want everybody to take the medications that are right for them at the right time. And I think one of the biggest examples of this is blood pressure medications. We've been told all the time that you've been prescribed blood pressure medications. Take it. You need to keep taking it. Don't stop taking it. But as patients get sicker and sicker, their blood pressure needs decrease. So they're in bed more. Their blood pressure isn't high. So if we give them blood pressure medications, they get too low. So that's why we talk about medications. And we talk about medications as a family, as a patient group, to make sure that we're giving the right meds at the right time for the right reasons. And a lot of times I have patients tell me, I am tired of taking my pills. And then we look at which ones we can stop. And that people really appreciate that. Hospice will make you die faster. I think this comes from, and we're going to talk a little bit later, is that patients come on to hospice too late. We have a 6-month timeline that patients can be on hospice, longer depending on what's going on. But a lot of times patients are referred really late. So we get them in the last hours to days of life. And I think people look at that and say, wow, they came on hospice and they just died, when in reality, they've been probably on that downhill decline for the last weeks to months. Hospice gives you morphine, so you die faster. Yes, morphine's a medication that we use. We use it for breathing. We use it for pain. We start in small doses for patients who need it. I think once again, patients come on late, they're in a severe pain, we have to get them under control, we give them that morphine, and patients can't let go to have a peaceful death if they're having lots of pain or symptom management. So we start low, we start working up. Morphine will not kill you. It will help you breathe easier, but it's one of those educations that we want to do with our families every time. And as long as you have a skilled practitioner working with you, we're not going to let people overdose on morphine. This one, they just put you in a corner to die, comes from my experience when I have worked in the hospitals, and people are worried that nobody wants to take care of their loved one when they're dying. And hospice, we want to be there. We want to take care of you. We want to be with our families and walk this path through them, no matter what it looks like. So if anything, we're there probably more than some families want us, but we also take our clue from the families and say, what is it that you need? We don't want anybody to feel like they're left alone during this process. And you can't see your doctor anymore. And this is true. A thing that we say to every patient who comes in, you get to pick who your primary care provider is who takes care of you on hospice. That can be your nurse practitioner, that can be your PA, your medical doctor. We ask the family who they want to choose, and then that provider gets to also say, yes, I'm comfortable enough to be that hospice physician. But we always have our hospice medical directors and providers to help us out. We all work under those orders of whatever doctor the family is choosing. And then once you're on hospice, you can never leave, that you're with us forever. This is not true as well. You can come on and off hospice as many times as you need. Sometimes we get patients on and they start doing better, and we call it graduating. They look like they don't need us anymore. We graduate them from hospice, and they can come back anytime that they need.
Teresa, I have a question for you.
Sure.
How does hospice deal with people with increasing anxiety and occasional delusions and paranoia, especially in a patient who is otherwise rational?
So as everybody starts changing and getting towards the end of life, we start seeing more agitation. It's a change in the electrolytes and different things. And so we start assessing the whole patient from every level, whether it's a spiritual, social work, pain, what's going on? Where is that agitation coming from? If it's something that's medication related, then we're going to start a little bit of medication. Sometimes our patients start having life review and seeing people who aren't there that the rest of us aren't seeing, but sometimes that's part of that life review. So we look at it and, is this scary to the patient? Is this scary to the family? If it's something that's not scary, we kind of be with them and walk them through that. And if the family feels like it's okay and they understand why it's happening, we can walk them through that. If it's something that's scary and upsetting, then we do start medicating, and we have a lot of different medications that we can work with to get that patient comfortable. And it's as much or as little as they need. Sometimes a family member will say we don't want them super knocked out, or the patient doesn't want to be knocked out. So we're looking at that, and we're working together with everyone to make them comfortable. Karen, do you have anything to add to that?
I'll just echo that. Really, you'll hear through this presentation that hospice is patient focused. So we really work hard to develop a plan of care that the patient is comfortable with. So, you know, if someone doesn't want to be heavily medicated, then we're going to do everything we can to respect that. We have lots of tools in our tool bag. Medication is just one of them, but there are many other things we can try. And again, if the patient's comfortable, then I always say, you know, there are no emergencies. If the patient is comfortable, you know, then we're in pretty good shape and we can just start handling it from there. So we'll go ahead and talk about who qualifies for hospice. So generally patients are referred to hospice if they have a diagnosis with a prognosis of 6 months or less. Our hospice patients often live much longer than that, and that is perfectly fine. But physicians are allowed to refer when, in their best guess, a patient has 6 months or less. And we like to say, you know, hospice, it's a good time to consider hospice when the burden of treatment outweighs the benefit. People are tired of going to appointments, spending, you know, their last few months where they're mobile and independent and interactive, just immersed in the medical world. So that would be a good time to reach out for a conversation. And there's just no harm in reaching out early and having those conversations. And I think many people would be surprised that they qualify to sign on to hospice much earlier than the norm. And if it is a little too early, we can give some guidelines for when you get to this stage, give us a call back. But I would say, and Teresa, you would probably agree, I think that most patients who reach out qualify fairly early to come onto hospice.
Absolutely. And I know we've said it a lot, and we'll say it more, is that we'd much rather have people come on earlier rather than later, so we can give them that best quality of life in those last whatever time they have left.
Yeah. So who pays for hospice? So really insurance, primarily we work with Medicare and Medicaid, but most all insurance has a hospice benefit. And so we're here to be able to figure that out with you. Are there copays? Are there deductibles? Medicare pays for hospice 100% and Medicaid pays for hospice 100%. If someone doesn't have insurance and they don't qualify, then that's where being a nonprofit comes in, and we will still take care of them to the best ability that we would anyone else and serve them well without benefits.
So what does hospice provide? We provide supportive care and symptom management at that end of life, in that last 6 months like Karen talked about. And what does that include? So the visits by the nurses that we talked about, who are experts in that end of life symptoms. What does it look like? What are we going to see? And it all is based on what disease process is happening. So they look at the pain, they look at the nausea, they look at vomiting and breathing and making sure that that's all managed. The nurses will go in and see our patients at the very minimum once every 2 weeks per Medicare requirements, but usually we're seeing patients 2 to 3 times a week. And this is where I always want to remind everybody that hospice isn't the caregiving in the home 24 hours a day, 7 days a week. That we teach the families how to do the care, or we help them hire caregivers out there. We have the hospice providers who we work under that direct all the care for us. So they're also with our Dr. Looney and Katrina and our providers who are hospice. They are experts, have done hospice a long time, and they're directing us as we go, available to us just via phone call all day, every day. We couldn't do it without them and love their support. So our hospice aides, who I always say do the most intimate of the work of all of us, they're there with the patients who are at their most vulnerable, helping them get in and out of the shower, giving that bed bath, a hair wash, a massage, a foot massage, where our families and patients just appreciate it and can just help them. And then sometimes the aides bring back to us stories that the patient was worried to share that they've shared now with them. So once again, that holistic approach and the whole team working together comes in here. The social worker's job is kind of anything that's not medical, anything that the nurses can't handle, we turn over to the social workers and say, help us with this. And counselors, they are amazing at finding resources. If somebody is at low income, getting them set up and working through that Medicaid network, working through the VA. We are both, we honor veterans programs, so we have a lot of work that we do with veterans in the VA. Our chaplains come in and do the spiritual care, whatever that looks like for our patient. That could mean talking about fishing, if that was what was important to them, or answering whatever questions that may come up that sometimes other people can't answer at end of life. And then we talked about our volunteers too, and we love our volunteers. It is part of Medicare says that we have to have a volunteer program that provides 5% of what we do. So our volunteers provide respite to patients' families. They help us out here in the office. Whatever might make somebody have a little bit easier process, we want to provide that. And then the biggest thing that I always want to point out is that our nurses are available 24 hours a day, 7 days a week, via phone or a visit if that's needed. Whereas before, without hospice, you have to call your doctor's office or you have to go to the hospital. We ask that our families don't call 911, that they call us first, because there's a lot we can do in the home that doesn't require a trip to the emergency room. And sometimes that's just a phone call to say, I just need somebody to talk to.
Teresa, I have another question for you both.
Sure.
Is there any counseling open to caregivers for patients who are not in hospice? So those caregivers that are helping patients that are served by hospice, are the caregivers able to get support as well?
Absolutely. So we truly feel that when we admit a patient to hospice, we're admitting their whole team, their caregivers, their family members, whoever is important to them, we want to help. And because sometimes it is hard when we see patients at assisted living, so they're the paid caregivers, they need help. They need this talk about what it is we do, how we do it, how we support them, and if they're struggling, what can we do? So the chaplains and the social workers and the nurses do lots of work with that, and love to provide that care to them. And also, I know one thing that we do is after death at these assisted livings or nursing homes, we offer services to them as families, or they are the families of patients at assisted living. So doing a memorial with them is sometimes very important.
So what about patients? What about caregivers for patients that are not in hospice?
So we're happy to answer questions if caregivers want to call us and talk to us. We, of course, are going to say, come to hospice if you need us. We do offer bereavement support 13 months after death for our patients, but we do open that bereavement support out to the community as well. So I hope that, Karen, do you have anything to add to that?
I would say that, yes, we do serve the community in a bereavement capacity. It isn't necessarily the full spectrum that our hospice patients have. We don't have really a timeline attached to that, but we can certainly do, short-term grief counseling and then do referrals to either a caregiver support group, or people are welcome to join our bereavement groups as well. So we won't turn anyone away who needs our help with bereavement.
So what else does hospice provide? I think a lot of people didn't realize that we provide all the equipment that somebody needs to be comfortable. So the main things we see is the fully electric hospital bed. It's going to be easier for somebody to get in and out of that bed or put their head up if they're having difficulty breathing. Easier for the family or caregivers to take care of that patient. A lot of times we hear, I don't want to give up my bed. And sometimes we put a hospital bed in the living room and people can be in their regular bed at night and have the hospital bed out where everybody else is. So whatever makes sense for our patients is what we want to do. Oxygen, if they're needing oxygen, we supply that. Wheelchair, bath bench, bedside commode. We're looking at the home to decide what is it going to be to keep that patient safe, to keep the caregivers and the family safe. So all of the medications that are related to comfort, we provide. So we talked about the pain meds a little bit. So that's, if they're in pain, we're going to ask them, what level of pain are you at? What level of pain do you want to be at? What is most comfortable for you? Somebody may say, I'm okay being at a 5 out of 10 on that pain scale if it means I can stay awake and see my grandkids. Some say, I don't want any pain, just get me comfortable. And we will look at that within what our parameters of pain medications and the doctors, and work with everybody to get patients as comfortable as they want to be. And then breathing medications. It's not fun to not be able to breathe. So we will provide those. Nausea medications, anxiety medications. I didn't write that on here, but we talked about sometimes we see what's called terminal agitation as the body is starting to shut down and people aren't quite ready to let go. So we see that agitation that we want to manage. And then constipation, and I always bring this up, is anytime we start somebody on pain meds and narcotics, we want to make sure we're managing that constipation, because 100% of our patients on narcotics are going to have constipation issues. So, and then we've talked about the bereavement support for 13 months after death.
So why have hospice? Really, I think the biggest benefit is the interdisciplinary team that comes to your home. They really circle around and make sure that all of your needs are provided for. So you don't have to spend that energy going out to doctor's offices, hospitals, labs, x-rays. We're the eyes and ears for your PCP or the hospice provider. And like Teresa mentioned, they're available with a phone call or a text immediately. We'll get the help we need right away. The patient-driven care plan. This is really about what are the goals of our patients and families. And it might be the first time in their medical experience that someone has said, this is your journey. Like, what's important to you? What's your goal? What's your priority? Teaching, listening, affirming, always listening, asking pointed questions, circling back to patient goals. What makes them comfortable? What is their priority? And then we really do like to prepare for what challenges might come. So we might start talking early about medical equipment or symptom management, teaching the family. So if someone is becoming weaker, you can expect them to be in bed more often, and this is what that care will look like. Encouraging life review. It's just part of getting to know the patient and family, which we love, is seeing pictures, hearing stories, listening about connections they have. Are there anything that's on their mind as they wrap up this journey? We want to be present to hear that information and do what we can to help. And then assisting in finding meaning. A lot of our patients, have had difficulty, have had trauma. I think life brings you that. And so really sorting through some of that experience to bring back, what has been meaningful to them. And again, talking about the bereavement support. A lot of families feel very reassured that even though, they might be dying, there's still going to be support for their family afterwards. And we're going to be there to help with referrals, just a listening ear, and help them through that grieving process.
How do we get a referral? So how is a referral made to hospice? The primary care providers or the specialists, the oncologists, the cardiologists, anybody related to that hospice or patient care can call hospice directly, fax us, send us an order through the medical record. If a provider has questions about when somebody should be referred to hospice, our docs and our nurse practitioners are available to them anytime. They can call us and consult, call either of the Coast or the Albany Hospice Team and ask those questions, tell them what's going on. A lot of what I do and what the team in the Valley does is talk to family and friends who just kind of give us a call out of the blue, or we go over to the emergency room and the floor and talk to families about what's going on. And this always leads me to, as we talk about hospice and care, sometimes we come in at a time where people are in a panic or it's a crisis. And if one thing I can teach all of us who are here with us today and everybody I meet is talk about what you want the end of your life to look like before it's a crisis. What is it that you want? What would you like to see happen? Who do you want to be there? That makes it so much easier than when that crisis does come and you can say, I've had this conversation with my loved ones and this is what she wants, and it just makes it easier, and it's a good conversation starter with families too. But we're happy to talk anytime. We can do what's called an informational visit. So if a family calls and says, this is what's happening with my mom, she's not eating or drinking very well anymore, she's had more emergency room visits, she's falling, do you think she is appropriate for hospice? We're happy to come make that visit and talk about what hospice is, do what we're doing today, see if they look like they're hospice appropriate, and if they are, we'll reach out to the primary care provider for that referral as appropriate.
So hospice being underutilized, we'll talk about that a little bit. There are lots of reasons for this. Sometimes patients are just not aware that hospice is an option or that they qualify. They might be waiting for their doctor to bring it up, and that's just not an easy discussion to have. Some physicians might feel like they're giving up on their patients by having that discussion. So we do lots of education with physicians, and we're also available to help with those conversations. People don't want to talk about the end of life. It's not a normalized discussion in this country, and so we're really comfortable with that. And again, glad to be involved. There might be a sense of giving up. We really try to highlight the fact that instead of giving up, it's really taking back your control of your plan of care, focused on your goals, your comfort, your priorities. People are afraid of the unknown. They just don't know what hospice is. And they might think that there's an expiration date to their hospice benefit with insurance, that I don't want to use it up too soon. And there is not an expiration date as long as we can continue to document that someone has a terminal decline. They can live well past 6 months and still qualify for hospice. The average length of stay, I think in the country, is about 35 days on hospice, but really people could qualify for this benefit for 6 months or longer. So I think our long-term goal, the long-term goal of any hospice, is to get patients on a little bit sooner. So we have time to build those relationships and really access all of the services that are available.
And I can't agree more with that with Karen, that, I think here on the hospice, our average length of stay is probably around 2 weeks, and we'd love to see our patients on sooner than that.
Yes.
If I can interrupt there, I do have a few more questions and a comment, so I'll start with that. On the question about caregivers and services for caregivers, one of our Samaritan employees noted in the chat that there is a general caregiver support group that meets monthly at the Center for Health Education in Newport. So if anybody is interested in that, you can go to the chat. Ursula Marinelli actually put more information in there. So you might want to learn more about that. And then a couple questions, and both of these are sort of related, so pardon me while I read a bit. So how does hospice deal with male UTIs? Specifically, how is the presence of a UTI detected, and how aggressively is a severe infection treated? That's one question. And then a similar question, if a patient has a POLST, does the facility send to ER for things like PNA and UTI?
I'm glad to answer the first question. So how does hospice deal with male UTIs? Really any UTI, we're going to look at the patient first, and really primarily, are they uncomfortable? What are their goals of care? A UTI can be a really normal end of life problem, but if someone's comfortable, they may choose to not treat that. If they're uncomfortable, then we're going to talk about options for that. So we could do antibiotic pills, we can do medications that numb the bladder. It really just depends on the patient goals, and we're glad to treat if that is what the patient wants, and they can swallow pills and it's in alignment with their end of life goals.
And I could touch on the second question. So you may have to repeat a little bit, but it talks about the pulse. So a pulse is the physician's orders for life-sustaining treatment, and that is what tells us whether somebody wants to have CPR or not, or allow a natural death. It also touches on whether they just want comfort measures only, or if they want full treatment. And a lot of times our patients in the community nursing homes have a do not resuscitate on their pulse, and that they want comfort measures only. But if those patients who are not on hospice, the facility's hands are kind of tied if things start to happen and they have a decline. And so that kind of forces those facilities to send to the ER, which causes angst in the ER because there's nothing really that the family or the patient wanted done at that time. And those are the times where I've talked to our ERs. It's like, call us and tell us that these patients are coming in. Let us have that conversation about hospice and what it is that the family's goals are and what they want. And the emergency room providers can make a referral to hospice right there. They don't have to wait for the primary care physicians to do it. We're happy because we're so close to both the Newport and the Lincoln City ERs to come over and do it. And I know the Valley is just as comfortable. The second part of that question had to do with pneumonia, and I can't remember, Natalie, what that was.
It was ER. Does, if a patient has a pulse, does the facility send to ER for things like PNA and UTI? So I think you kind of answered it.
Okay. And the facility should be sending that. So if they're not, I would always call the facility and ask if they have a pulse on hand.
Oh, go ahead, Teresa.
Oh, I was just gonna say, you could talk about our common quotes from families.
Yeah, that's great. So we send out a patient experience survey, and these are some of the things we hear back from patients and families. Just the acknowledgement that hospice helps people die naturally on their own time. We allow for a natural death that's comfortable and dignified and supported. Hospice redefines hope. Hospice helps people live as well as they can for as long as they can. And our goal is to improve quality of life, and that people wish they had known about hospice sooner.
We hear that so many times about, we wish we could have had you 6 months ago, and a lot of times they could have. And so
Right.
those referrals can come. I like Karen talk about the hospice house in Albany.
So we are so fortunate to have one of 3 hospice houses in the state. We're considered a small specialty hospital for our hospice patients that are signed on to service in either the coast or the valley. So patients can come to the hospice house for symptom management. Maybe their caregivers are just exhausted and they can't do it anymore. Maybe someone's having a pain crisis, some other symptom management crisis that we can really address very quickly in the hospice house. It's staffed 24 hours a day. Our patient ratio is wonderful. We have a provider on site, so people can get really excellent care, get their symptoms, under control quickly and get back home. It was built in 2012 by the Albany General Hospital Foundation and donations. We're in Albany, Oregon, and again, just one of 3 in the state. So this is our memorial wall. We have this tree that was built by a local physician. He also was really integral in the Carousel project in Albany, if anyone's been there. The woodworking, it's by Dr. Goby. He's amazing. And people can purchase a copper leaf and have their loved one's name applied to the leaf. And all of the donations go back into our foundation. And just a picture of our family and dining room. We're not gathering in large spaces right now, but in normal times, people have Thanksgiving here. We've had a wedding. Just families can gather and kind of have a nice peaceful place, and kids are allowed. But for now, our hospice houses, our dining room is closed right now. Our bedrooms, we really tried to capture a home-like environment while also being able to address any medical situation that comes up. Families are welcome to stay 24/7. We have fold-out couches and chairs. We also have beds in our common areas that families can use. And they have private bathrooms.
We're coming to the end and opening up for questions. So we're happy to have anybody call us anytime. They can talk to myself, they can talk to Karen, they can talk to our charge nurses, anybody who's available to talk about what hospice is, if we're appropriate for you. We're happy to answer questions anytime, and we are so glad that you joined us today. And so we will open it up to questions now.
I do have another question that was entered into the chat. And for anybody, if you have a question, please go ahead and put it in the chat, and then I'll read it off to our presenters. So this has to do with bed capacity. For such a wide service area, 12 beds is not that many. So are there any plans to expand bed capacity?
It's not, you're right. I mean, there aren't that many beds for such a wide service area for sure. And I think the challenge is, any hospice can apply for a certificate of need with the state and go down the road of opening a hospice house. But really financially, they're difficult to manage. And we are just so lucky to have support from our foundation and Albany General Hospital that they really feel this is a huge community service and benefit. But I don't think at this time there are plans for any other hospice to open a hospice house. One of the hospices in Benton, Partners in Care, they are expanding from 6 beds to 14. And then Peatmore Hospice House in Springfield has 14 beds, and that's it. And Hopewell House was our 4th hospice house in Portland, and they did close down the year before last, I believe.
Okay, another question. Does your hospice house serve memory care patients who are bedbound and on Medicaid?
So our hospice house does have the option, if someone's on hospice, there is the option to live here at the hospice house, but Medicaid does not reimburse for room and board in the state of Oregon, unfortunately. So it would be private pay, much like a nursing home. So our private pay rate is very comparable to a stay in a nursing home or a memory care facility. So we do have that capacity. Unfortunately, Medicaid does not pay for that.
Okay. And how do you determine when to keep someone past the 6 months or to graduate them?
So I could take that. I saw a question. I'm trying to get the slide back up for everybody to see our phone numbers. So we meet every week or every 2 weeks, depending on where we are, and we discuss every patient that is on, and we're talking with the whole disciplinary group about that. So what's happening with our patients? Are they declining? Do they still meet that criteria? We have a list of criteria that Medicare gives to us that says they should be doing this. As long as we can document that functional decline, we're going to keep them on hospice. And so sometimes we have a current patient who's, I think, 1.5 years, 2 years on right now. So we keep them as long as they need. Also, if we're looking at it and patients, sometimes we move people from home to that higher level of care, and just having that 24-hour caregiving service helps them thrive. And so then as we start seeing them, they're gaining weight, they're eating better, their pain is well controlled, we've managed their medications, that they're looking great. And that's when we decide to discharge and let them move on, and then they can come back to us anytime. There's unlimited benefit periods with hospice, so as long as they need to have us, they can come back. And then patients and families can also revoke hospice, which means we feel that they still need us, but the families want to try something new, or maybe there's a new chemotherapy or something else that the family wants to try. They can revoke hospice to come back on later if they need us.
Great. So what is palliative care? How does it compare to hospice?
Well, that's a really good question. So palliative care in the traditional sense would mean that patients can pursue some forms of treatment and then also have the support of hospice. I think in this country where it's a little bit of a divided issue and it's in the control of the insurance companies. So in the Valley, palliative care is really more of a consult service in the hospitals to help families make those decisions between continuing treatment or going to hospice for comfort care, not really doing both. We do have an outpatient palliative care program in Linn County through Samaritan, and they really only serve congestive heart failure patients right now. And so I think it's a slow time coming, but it is a wonderful idea that I hope we can grow. On a side note, most pediatric patients are allowed to have palliative care and hospice at the same time. So that's a great start.
And that's something that we didn't talk about, is that both of our hospices take care of all ages. We've had newborns all the way to, I think, 106 is my oldest patient.
Wow, 106, bless their hearts.
Yeah.
Okay, here's another question. Is there a minimum level of hospice support to be on the program? For example, can it be as little as 1 or 2 days a week until more help is required?
Absolutely. I mean, really, like Teresa said, Medicare requires us to see patients once every 2 weeks. Right now, we have a telehealth waiver, so we can even do that through telehealth if that's the patient's, wish. So really, the only person on the team member they have to have is a nurse, and we can really work with patients on how little or how often they want the nurse to come. We do like to encourage at least meeting a social worker in case emotional, needs come up. It's really nice, but we'll definitely dial back the support as much as we can if that's the patient's wish.
Are there any other questions? We still have about 10 minutes. I really appreciate everybody's participation in the chat today. And thank you to both of our presenters for such informative information.
Oh, thank you guys so much. It's such a pleasure.
Thank you. It's been great. And like I said, call us. Happy to answer questions. Happy to talk about it.
Absolutely.
You're getting all kinds of applause.
Oh, thank you.
Thanks.
This is such a personal subject that it is you're like you said, it's a difficult conversation to have. And I just support what you said, that it's so important to have those conversations before you have to have those conversations. So thank you for that. We
You know,
have
something I just remembered that I wanted to talk about is we do a Light Up a Life service every year to remember our patients. It's going to be virtual again this year. We started that with the pandemic, and forgive me, I can't remember the dates after all those meetings, but towards the end of November it will go live, and it will be available for the next year to talk, and it will show all of the patients who we've served over the last year for hospice.
It goes live on November 19th.
Thank you.
And that's on the Samaritan Health Services website.
Oh, and we've got Taylor and Carla adding the link for Light Up a Life going live on November 19th. So if any of you are interested in participating in that wonderful event, it's something that we've done in the past in person, but obviously because of COVID, we cannot. So November 19th, you can log in through that link there and participate in our Light Up a Life ceremony. A question: is the recording of this presentation available to us following this presentation? You bet, Wendy, it will be available.
Yay, great.
I have a thank you, Karen and Teresa, and a little heart. So got more and more people thanking you all the time.
Thank you.
Thanks so much for taking the time with us today.
Thank you.
Do you work with death doulas? Another question.
We've started to see more death doulas in the last couple months, and a death doula is somebody who comes and just sits. It's kind of like the labor of birth, it's the labor of death, and that they do start. I've seen a couple here on the coast. What about you, Karen?
You know, I haven't attended a death with a death doula, but I do read a lot about that, and I think it's a lovely practice. It is so similar to the labor of birth, and who does not need a support person for that?
Yeah.
How do the foundations support in-home hospice patients?
Oh, we love our foundations. Yay. Thank you, Ursula. So the foundations, people donate in memory of their loved ones who we've served, and we use that money for massage, music. When we could, we have a flute player on the coast, so we can't send him out right now because of COVID, but that foundation funds support that. Transportation is very expensive between the hospital and home and not necessarily covered under the hospice benefit, so we use foundation monies for that. We have, in the years that I've done it, we've had a wedding for families that we moved up because their dad wasn't going to make it. We bought a bike for somebody once. Anything that's going to help support the family and give them good quality of life. Paying a bill, we've done that. Mortgage payments.
Gas cards, hotels to come and stay and visit. Tons of staff education. The foundation has sponsored workshops for our staff, certifications. Oh my gosh, so much support from the foundations. They're incredible. It's a great way to support hospice is to donate to the foundation in memory of a loved one.
And you can support any of the foundations. There are 5 of them associated with each of the Samaritan Health Services hospitals. Here at North Lincoln Hospital Foundation, you can designate a gift to hospice, and that money will go directly to those services. All right, well, I want to thank you, Karen and Teresa, again for your wonderful presentation. And thank you to all of our guests for joining us today. Please check in soon. There will be another MedTalk coming up. We do them once a month, and we look forward to you joining us again. All right, have a great day, everybody.
Thank you. Take care.
Bye.